You people work in the labs, and whatever you do the research, we translate it into patient management. So you should be aware what we are doing at bedside, how we treat the patient, broad concept, how we do that. And if I go too high, like it's not for your use, just stop me wherever I am exceeding that. Okay? And just to give an introduction, the scale of the problem, cancer ranks as the leading cause of death. Cancer's rising prominence as a leading cause of death partly reflects marked decline in mortality rates of stroke and coronary heart disease relative to cancer in many countries. So we say that the cause of mortality, we say 3 C's: cancer, car, and cardiac. These are 3 major killers. So cancer is one of them, and it is increasing day by day, as you all know. New cases worldwide, nearly 2 crores worldwide, and 15 lakhs we have in India per year, accounting for nearly 1 crore deaths in 2020 data. So it is a huge magnitude, and we have to deal with that. So if we see the incidence, the site-wise, worldwide, breast cancer in females is the commonest one. And the second one is lung, then colorectal. This is worldwide data. However, if you see sex-wise male-female, in worldwide, lung is the commonest one, and in females, breast is the commonest one. And in India, if you see, then head and neck cancer is the commonest one in males, and breast cancer is the commonest one in females. And the next common is cervical cancer. Few years back, this was the commonest one, cervical cancer. But now, the breast cancer has exceeded. The reason being, anyone? Lifestyle. The lifestyle is changing very fast, and cervical cancer is related with poor hygiene. That is improving, and the population is moving from rural to urban side, and the lifestyle is continuously changing. So there is more incidence of breast cancer now. So you see in females, breast and cervix constitutes almost half of the overall incidence. So we have to be very aware of. I can see more of females over here, so you should be aware what is the problem. And if you see the risk factors, they can be biomedical factors like genetic susceptibility or hormonal factors in females. This we cannot change. These are there. But the lifestyle factors like smoking, alcohol, physical inactivity and obesity, this is also very increasing problem and leading to more and more of cancers. Then infections, diet, these all we can change with awareness. And environmental factors like exposure to sunlight, radiation, occupational exposures, pollution, these are all environmental factors which cause cancer. And if you see the mutations, breast also has a very high component of inheritance. And others are lung, glioma, head, neck. So how smoking causes cancer? The carcinogens, they enter the lungs. There is a DNA damage, and there are other chemicals which make the repair more difficult. And then there is carcinogenesis. And tobacco itself is related to 12 different kinds of cancer, which are shown here. So we have to see that we can prevent occurrence of all these cancers if we don't smoke or we take tobacco. Similarly, alcohol. 7 different kinds of cancers are related with alcohol intake, and the larger the dia, the So these are infections. Many cancers, they are related to infections. And you can see hepatitis B and C. HPV is the commonest one in cervical cancer. I think you must be knowing 16 and 18 variant is it has the highest association with cancer, cervical cancer, gastric and leukemia and many more. They have some correlation with viral infection. These are environmental carcinogenesis genes which can lead to occurrence of cancer as shown over here. So what is screening? I think you all must be knowing about the screening. Screening applies to a normal population. And the aim of screening is to reduce the number of people who die from the disease by diagnosing it in an early stage. So that at the time which is where we can cure them and prevent cancer deaths altogether and reduce the number of people who develop the disease if we diagnose it in a pre-cancerous stage. So cancer will not develop. And how this happens? Why screening works and we should go for it? Like this process, if we talk of cervical cancer, these are the normal cells, and once with the infection like HPV infection, there will be initiation of carcinogenesis, and by the time it converts into frank malignancy, there is a time period of 5 to 20 years. So this is a long period. If we are aware, if we know that these symptoms can lead to cancer, then we will diagnose it in an early stage. So we should make all efforts to become aware of the symptoms and diagnose it in early stage so that we can prevent mortality and can cure the cancer. So screening is available for these particular malignancies, and mostly it works in breast cancer and cervical cancer. Lung cancer, it is controversial whether to go for it or not very effective. Similarly, the other two. So I'll talk about these two. Breast cancer, when to go for screening. A woman has to start if there is some history, high risk or any history in the family, then 40 to 44 years. But from 45 years, female should undergo annual mammography. Mammography, are you aware of? No? How many know about mammography? Only 2. Okay, I will discuss that in my future slides. So, 45 to 54 is the 10-year period where one should go for annual mammography. And 55 and older can switch to a mammogram every other year, means alternate years. You can go for it, or they can choose to continue yearly mammograms if they are more conscious and they don't want to take any risk. They can continue with every year. Screening should continue as long as a woman is in a healthy state and has a 10-year life expectancy. तब तक कराते रहना चाहिए. One should not stop. Okay, and women should be familiar. Now, this actually we recommend, but I don't think people go for it. Even literate people, they not go for it regularly. So what can be done in our setup? Women should be familiar with how their breast normally look and feel, and should report any changes to a healthcare provider right away. अगर आपको कोई भी changes लग रहे हैं, you should immediately report to a nearest doctor, whoever is your family physician. And what is this BSE and CV? This is very important. And I will take this opportunity to tell you all what this is and what should be done. BSE is breast self-examination. Anyone? What is this? Yes?
And to examine their own breast with the help of the fingers. 3-finger test is used for self-examination.
How,
it can be done every 3 months, and like 1 week before and 1 week after your PMC. And
okay, have you read this somewhere?
No.
Or just the general knowledge?
I read it in.
Okay, so you are more or less correct. But what BSE is breast self-examination, and we suggest females to do this every month. This because it takes nothing, just your few minutes. Okay, and when to do it, that is very important. So in premenopausal females, they should do it on 6th day of their menses. Day 6 you can call it. That time your breasts are very soft and you can even pick up the smallest nodule if it is there. Okay, so you have to do this. And for postmenopausal females, since there is no menstruation, so on any fixed date of the month, maybe first of the month, they should do regularly their breast self-examination. And I must tell you, this is very, very important. ये इतना ज़्यादा फैल रहा है society में, as I show you the data, it is increasing. The person sitting next to you might be having this and is not aware. और दूसरा ये भी होता है कि अगर ब्रेस्ट में कोई लंप है भी, so they are scared. मैं डॉक्टर के पास जाऊंगी कहीं डायग्नोस ये ना हो जाए कि कैंसर, तो they try to don't reveal their problem, and in this only it keeps on increasing in size, and then when they report to us it is very big, very advanced stage. जबकि ये बहुत ही easily आप बहुत early stage में इसको diagnose कर सकते हैं. And we have seen literate people coming to us with advanced stages. So there should be awareness for this, that you have to examine your breast, and if you keep examining your breast, then you will be the best person to pick up the smallest nodule. ठीक है? So, and what is CBE? CBE is clinical breast examination. ये हम लोग इसको प्रमोट करते हैं कि whenever any female goes to a doctor, a gynaec or any doctor for any complaint, maybe viral fever, so she should take the opportunity and get her breast examined by the doctor. And हम लोग doctors को भी बताते हैं, gynecologists को भी बताते हैं that whenever female comes to you, you examine the breast. So that is your clinical breast examination. So it takes only few minutes, but very, very important. Now similarly, cervical cancer is also important and very like the magnitude is very high. So screening here begins at the age of 25, and if the sexual intercourse starts before this, means marriages take place at 17, 18 years also. So we can start from there. From 25 to 65 years, this HPV testing along with pap smear has to be done at every 5 years, and if only single test is done, then every 3 years. So this is the recommendation, and vaccination is also available. Are you aware of this?
Yes, ma'am.
You got yourself injected?
Yes, ma'am.
Who? How many? One only.
It was 2 and in a duration of 1 week.
So the exact dosage is 3 doses. 016, and two vaccines are available of 2 companies, but the problem is it is very expensive, 3,000 per dose, and the other thing is that the indigenous vaccine is coming up, it is very cheap, and you have to continue this screening process despite of getting vaccinated. Why? Because it takes care of only 2 strains, 16 and 18. So all strains to hang. So if you will stop screening, then you might get affected with the other strains. So we don't have that much of experience that after getting vaccination there won't be any incidence of malignancy. Okay? So now coming up to how we approach a case. A case of malignancy comes to us, then how do we approach that patient or work up that patient? So we take a complete personal and family medical history along with the comorbidities if he is diabetic or any other problem is there. Then thorough physical examination is required. Then histopathological confirmation. जहाँ पर भी कोई problem है, तो we have to take out a tissue or a cytology by FNAC. FNAC is fine needle aspiration cytology. This has to be done to confirm which type of malignancy it is. Okay, even if we deal with breast cancer, it can be the patient will disappear. This happens, I think you are aware. So we have to convince them that this is going to tell us how to treat you. Then tumor markers are there for diagnosing, staging, prognosis, predictive markers. There are many markers, you must be aware. Then imaging tests are there to see the extent of disease, then a routine blood test. And then the performance status and nutrition status of the patient is very important. Seeing the patient whether he will be able to tolerate the treatment which we will give is very important. And then other systemic examinations to see if there is any other problem in the patient. So how we work up the patient, what investigations are required. So the simplest one is X-ray imaging, and we do this for seeing if there is any lung metastasis. Most of the time, you know that the cancer spreads in the body, okay? And the commonest spread, the organ is lung, where the metastasis goes. So we have to take a simple X-ray test to see this. Mammogram, as we were talking about, mammography, this is how it looks like. And the recommendation has already been told to you. So there are two types of mammographies, conventional one which is the normal X-ray and the digital one where you can immediately see on the screen what is the problem. And this speculated mass with a microcalcification is suspicious of malignancy. So if there are small punctate calcifications with some speculation in the mass, that is where we have doubt and we have to confirm that whether it is malignant or not. Otherwise you can get dense masses but all are not malignant. So don't get scared that there is a mass. So other modalities are ultrasonography, you all must be knowing about it. So it is cheap, it is non-invasive and there is no X-ray hazard in that. So this is commonly utilized and biopsy and FNAC करने में हम इसको localize करने के लिए we use these ultrasound machines. CT scan, you all know what CT scan is, and we get this kind of picture by CT scan. So this is good at seeing the bony abnormalities. Okay, and some soft tissue density also we see on these scans, but not with too much of clarity. So if we have to see the bony involvement, we go for CT scan. However, if we are interested in seeing the soft tissue extension, so soft tissue extension is more clearly seen on the MRI, magnetic resonance imaging. So this is how we see on MRI, these are the images, and soft tissue details are more clearly seen on MRI. Okay, and then what is PET CT? Is it same as CT scan? Any idea? Are you with me, whatever I am telling you, or is it more for you? PET CT, no idea? How is it better than CT scan or MRI? Okay. So PET CT is positron emission tomography, and this is utilized to see, like if here I am seeing this abnormality, okay, soft tissue mass is seen here, but this can be just a fibrotic mass. There might not be any active malignancy in this mass. Okay, so by CT scan or by MRI, we will just be able to pick up this abnormality over here. But if there is any active malignancy in this particular mass, that will be visible on PET CT. ठीक है, उसमें ये इस तरह से light up हो जाएगा, and this will show that there is active hypoxia, angiogenesis, proliferation, apoptosis. These are all processes going on in this particular mass, and this is an active mass. So if there is no such thing going on, then you won't be seeing any reflection over here. If it is just a plain fibrotic mass, okay? So this is how this is becoming very important in our specialty, just to know whether this abnormality is active or not, and that will change your entire treatment. And this is mostly utilized in knowing if this particular malignancy has spread anywhere at other side in the body. Because this scans the whole body, and if it is spread anywhere else other than this particular local site, then we will be able to know it. So this is bone scan. Bone scan is similarly like PET CT. This is a cheaper modality, and this is done by SPECT CT machine, and this picks up only spread in the bones. If there is any bony abnormality or any spread in the bones, this will pick up. And technetium 99, if you have heard of, this is injected in the body before scanning, and then it goes in the bones, and you can pick up if there is any spread in the bones. So now, how we do the staging? For different malignancies, we have different staging system. But broadly, we can say that if there is just carcinoma in situ, so that is stage 0. And if it is a localized small growth, it is stage 1. And stage 2 and 3 are early locally advanced, late locally advanced. Means local है, लेकिन थोड़ा कम spread हुआ है, और 3 में है कि it is still local, but it has spread to the regional lymph nodes maybe, but not in the entire body. And stage 4 is metastasis into the distant organs. Okay, so this is a broad staging workup. What are the types of treatment available at the moment? So there are 3 major modalities: surgery, radiation, and chemotherapy. And these are newer things which are coming up day by day. Immunotherapy, you might have heard of. Anyone? Immunotherapy, what is that?
Ma'am, body cells, with the help of nanoparticles, we inject our immune cells.
So it is the details I am not going to take up here, but it is just to activate your immune system so that it takes care of the malignancy which is there in the body. And hormone therapy, against certain malignancies, they are hormone responsive, like the commonest one, breast cancer. Okay, so breast cancer, we give hormone treatment also to patients. Targeted therapy, what is this? Yes. So this is the future, and what we do right now is with surgery, radiation, chemo, we cannot distinguish whether this is a malignant cell and this is a normal cell. So it takes care of both the things. But with targeted thing, we just identify that this particular cell is malignant or there is a problem, and we have to target that only. So that is detected by certain antigens or some receptors over there, and we have targeted agents which will go over there at that particular site and will affect that site only. So this will have advantage in terms of less of side effects, because normal cells will not get affected. Okay? And this is the future. Day by day, many targeted therapies are coming up. So for breast cancer, we have the commonest one is trastuzumab, Herceptin, where we have HER2 receptors, and this goes directly to those receptors and blocks it. So the growth stops. So this is the future. And stem cell therapies again for the leukemias and many more malignancies which have a systemic effect. So these are the various modalities available. Now talking about 3 major ones. So by surgery, what we do is we remove the entire part which is affected by malignancy, and the margins are very, very important there. Whether you have achieved negative margins or not, when you remove that tumor is important. So sometimes we get positive margins, then we have to re-excise, or if that is not possible, then we have to give extra sterilize that area. Okay, and chemotherapy, this is the drugs which are injected through the veins, and it takes care of the systemic spread, means the cells which are circulating in the body, in the whole body. Then if you give chemotherapy, it will take care of that spread of the cells in entire body. But what radiation does, it again takes care of the local problem. So what normally is done in the treatment of any malignancy, that we remove the tumor first by surgery, and then we sterilize the tumor bed by radiation, and we add chemotherapy if we think that this is a malignancy which has the tendency to spread in the body. Then we will add chemotherapy to that local treatment. Clear? Any doubts? So you need to understand this, because you will be dealing with this, or you should have at least a broad concept how we treat the patient. So first surgery, and then sterilizing the tumor bed and adding chemotherapy if it is needed. So there are certain malignancies where they have a tendency to spread in the entire body from the beginning, and this is the commonest one is breast cancer. So breast cancer की एक छोटी सी भी गांठ होगी, so you will see that the patient undergoes chemotherapy. Why? Because it has a tendency to spread in the entire body. So that is why now we have come up with the concept not to remove the entire breast, because the smallest even lump is spreading in the entire body, so we have to give chemotherapy. So why to remove the entire organ? Just remove the lump, give radiation to the local site, and save the organ. So at many malignancies now there is an organ conservation strategy. So we don't remove. पहले क्या होता था, पूरा organ निकाल देते थे, amputation कर देते थे. But now with advancement in the science and technology, we are now conserving the organs with the help of multimodality treatment. Means just removing the affected part, giving radiation, and adding chemotherapy. So I'll just deal in short about the three major malignancies which we encounter day in and day out, and that is the head and neck cancer, the commonest one, and how we treat them. Stage 1 and 2, which is the small disease, and it hasn't spread to any further, and there we do surgery or radiotherapy alone. Most of the time it is surgery alone. We just remove the tumor, and depending on the histopathology report, if there is no need, we don't give any treatment further. But most of the time, हम लोग अभी इतने lucky नहीं है कि patient हमारे पास इतना early stage में आता हो. So they come with advanced stages, and we have to add radiation after removing that tumor. Most of the time it happens. So combined modality में हमारे पास surgery, radiotherapy plus minus chemotherapy if it is required. Or if surgery is not at all possible, the lesion is advanced in such a stage that surgery is not at all possible. Or if we do surgery, it will be very morbid. There will be a lot of morbidity in that. So we just treat by chemotherapy and radiotherapy. So here chemotherapy has a dual role. One is that when we give chemotherapy along with radiation, this is very important for you people. When you come for sample collection, patient undergoes concurrent chemotherapy also with radiation. So this has a role of radiosensitization. When we give chemo along with radiation, it enhances the role of radiation. So this is given in a small dosage. And when we give it separately at 3 weekly schedules, then it is a higher dose. And it takes care of the systemic spread of the entire body. But here when we give it in a small dose, it actually enhances the effect of radiation. So we call it as chemosensitization. On when different modalities are available, the modality that gives maximum chance of cure should be used. ये हम कैसे करते हैं? अगर हमें कोई lesion है, हम कहेंगे कि सर्जन कह रहा है हम इसको ठीक कर देंगे, और रेडिएशन वाला भी कह रहा है हम इसे ठीक कर देंगे. And you will have equal chance of cure with both the modalities. Then which one will you choose? The one which has a लीस्ट मॉर्बिडिटी, जिसमें साइड इफेक्ट्स कम से कम आएंगे, हम उसको चूज करेंगे। तो पहला हमारा एम होता है क्योर, और दूसरा एम होता है क्वालिटी ऑफ लाइफ, उसको इंप्रूव करना। Then the management of breast cancer, broadly about this. So treatment plan depends on factors like molecular markers, tumor size, patient age, performance status. Many things are there when we take decision. But broadly, early stage disease, what we do is we do the surgery first. Why? Because the chances of systemic spread are less, but they are there. As I told you, breast cancer is very notorious for having systemic spread. So we have to add chemotherapy. But in early stages, we do it later on. First, we remove the tumor, and BCS is what? Breast conservative surgery. And BCT is therapy जिसमें कि radiation include होता है. तो if we conserve the breast, तो हम सिर्फ lump निकाल देते हैं. Then it is mandatory to add radiation over there. ठीक है? अब बिना radiation के सिर्फ lump निकाल करके it is not enough. It will have recurrences. ठीक है? And अगर हम ये नहीं करना चाहते, रेडिएशन नहीं देना, या फीमेल is very like conscious and she doesn't want to conserve the organ, तो वो बोले कि नहीं आप पूरा निकाल दीजिए, मुझे कोई रिस्क नहीं लेना है, तो then we go for mastectomy, and there radiation is not essential then. ठीक है? Only removal of entire breast will be good enough, and then we will have to add chemotherapy, hormone therapy depending on the receptor status. जो एस्ट्रोजन रिसेप्टर, प्रोजेस्टेरॉन रिसेप्टर अगर ये उसके टिश्यू में पॉजिटिव आया है, then only she will receive this and targeted therapy in the form of trastuzumab. Okay, so if that is positive, then she has to undergo this therapy also. And locally advanced disease में क्या करना है? Reverse हो जाएगा. We will start with this chemotherapy, hormone therapy, targeted therapy, because this will take care of your systemic spread. So in advanced disease, we have to take care of the systemic spread first, and then we will remove the local tissue. ठीक है? Clear? So I'll skip this. This is too much of text. Now coming to cervical cancers, how we treat them. For early stage, again here surgery alone is good enough. You just do the hysterectomy, and it will be taken care of. And depending on the histopathology, there are certain factors where we have to add radiation later on, but most of the time it is not required. For locally advanced, we have the options of surgery followed by radiation, or radiation alone, or radiation with chemotherapy. These are all options available. But this option, surgery with radiation, has many side effects. So we should choose if we are sure that doing surgery will not need radiation later on, then only go for surgery. If we think the size is quite big and she will land up with post-op radiation, it is better to treat with radiation alone. This is very important in cancer cervix. दोनों modalities जो हम use करते हैं, then the side effects are very high. Okay, and what we do in sorry, this is not for chemo, this is for radiation therapy. EBRT is your external beam radiotherapy and brachytherapy. Are you aware of this? What is external beam? What is brachytherapy? No. Okay, I have few slides. I think they are there. And then metastatic disease, cervical cancer, if it is there, then the intent of treatment is palliation. We have to just take care of the symptoms. We cannot cure the patient. Only 3-4 slides are left. So I'll tell you a little bit about radiotherapy, how it works. So these are the two varieties, broadly the categories: external beam radiotherapy and brachytherapy. Okay, so this is brachytherapy, but the picture shows for head and neck cancer, and we have this for cervical cancer also. I have not pasted the picture over here, sorry for that. But after giving external beam radiation in cervical cancer, you can see the pelvic bones here. So we plan the patient for external beam, and after that brachytherapy is given. This is actually given in fractionated form. Multiple fractions are given. Are you aware of this? No? No. Family में कभी किसी का radiation नहीं हुआ, you are not at all aware of that. Okay. So I have to tell you because this is very important modality for cancer treatment as far as treatment is concerned. So external beam radiation is given by two machines. One is the cobalt machine and the other one is the latest one, the linear accelerator. Okay, and cobalt is now more or less obsolete. We have two cobalts and it treats mostly the palliative patients which are too advanced. But for the patients where we expect cure, we should go for treatment with linear accelerator machine. Okay, it has these less side effects. And why we give fractionated treatment, radiotherapy, multiple fractions. एक बार में treatment नहीं होता है. Patient has to come for repeatedly for treatment, like for months, maybe 25 fractions, 30 fractions. Then only the whole treatment gets completed. So why is this done? So basically there are 4 hours. The first one is repair mechanism. It acts over there, and sorry I don't have the pictures. I'll just tell you how it works. So repair किस चीज का होगा? Once we give radiation to the local site, what we want to get repaired? Normal tissue. So we want the malignant cell to be killed and the normal cell to be repaired. So we give time interval for the normal cell to get repaired because that takes faster, that happens faster as compared to malignant cells. तो जो टाइम इंटरवल है वो ऐसा होना चाहिए कि malignant cell तो नहीं रिपेयर हो पाई लेकिन normal cell रिपेयर हो गई. That is why we give it in a fractionated form. ठीक है? The second R is redistribution. What does this mean? You are aware of cell cycle? There are phases in cell cycles: S phase, M phase, G1, G2. ठीक है? So radiation is effective maximally in G2 M phase. Okay, end of the G2 and M phase where there is division of the chromosomes. So their radiation is maximally effective. So we want all the cells to be in that phase, but this is not possible. If we give radiation in one time, the cells will be some in S phase, some in G2, some in G1. So those cells which are in G2M, they will get killed, the rest will be spared. So next time when we give radiation, the cells which have moved into G2M, they will get killed. So this is how it works. So this is known as redistribution. Okay. And the third thing is reoxygenation. This is also very important. When you see a malignant mass, so there is necrosis in the center mostly because there is very fast mitosis, and the cells are in the center, they get necrotic. Okay, and there is less of oxygenation there because the vessels are compressed. They are lying compressed in the center. So their radiation will not be effective. Radiation works only when there is presence of oxygen. Okay, I am not going to that detail, but for radiation to work, oxygen is essential. So in the center, there won't be any effect of radiation. So once the peripheral cells are killed, there will be decompression in the vessels in the center. So oxygen flow will enhance and the cells will become radiosensitive. So in the next fraction, they will get killed. So this is the basics of giving radiation in a fractionated form. And that is why सर्जरी एक बार में हो जाती है, कीमो एक बार में चढ़ने की, कीमो की भी कई साइकिल्स दी जाती हैं, लेकिन रेडिएशन के लिए आपको लगातार डेली ट्रीटमेंट के लिए आना होता है. ठीक है, एंड दिस इज द बेसिक्स फॉर दैट. So by external, what we do is we give radiation from a distance, and in brachytherapy we treat from within the tumor. We put the catheters or the needles or applicators, and then we put the radiation source inside, and it gives a localized, very high dose to that particular area. Okay, so that is brachytherapy. Now, external beam therapy with advancement in technology. Earlier, with cobalt machine, mostly we used to do this conventional 2D method where we give one anterior, one posterior field. Okay? So there was this kind of distribution, and the entire tissue inside this box gets irradiated, resulting into too much of side effects. Okay? But now what is happening with the advancement of technology? We have 3D conformal radiotherapy and IMRT. IMRT is the latest term, you should be knowing about it. This is intensity modulated radiotherapy. What is the advantage of this? This is how we get the shaping of the dose distribution. ठीक है, हम इसमें मल्टीपल साइट से हम रेडिएशन इसमें फायर करते हैं और कंप्यूटराइज्ड प्लानिंग होती है इसकी, और उसमें हम ये देख लेते हैं कि जो हमारा टारगेट ऑर्गन है उसको हाईएस्ट डोज पहुंचेगी, और जो हमारा नियरेस्ट एडजेसेंट विसिनिटी में जो ऑर्गन से जिन्हें हमें सेव करना है, इनको हम कहते हैं OARs, ऑर्गन एट रिस्क, इनको हमें सेव करना है। तो इसकी डोज हम कम से कम रखना चाहते हैं सो दैट कि फ्यूचर में उसको साइड इफेक्ट्स ना हो। And this is how very nicely this dose gets painted on the area, and then we deliver, and there is cure. We can escalate the dose here where the cancer cells are present. तो जब हम पहले करते थे तब हम उतना डोज नहीं दे पाते थे क्योंकि हमारा नॉर्मल टिश्यू आ रहा होता था उसमें। अभी यहाँ पर हम नॉर्मल टिश्यू को स्पेयर कर ले रहे हैं, इसलिए हम यहाँ डोज बढ़ा सकते हैं, तो क्योर रेट भी बढ़ेगा और साइड इफेक्ट्स कम होंगे। So this is the beauty of the technology. And how we do this? First of all, we take the patient for CT scan, ठीक है, and then we take this images onto this computer, and then we delineate कि ये हमारा organ at risk है, ये हमारा tumor है, हर एक slice पे we delineate एक organ, और उसके बाद ये plan evaluation, dose planning होती है, किस तरीके से हम organs को save कर सकते हैं। Then we do the plan evaluation, quality assurance कि हमने जो लगाया है, जो plan किया है वो execute हो रहा है कि नहीं हो रहा है, ठीक है। और उसके बाद ये मशीन है जहाँ पर पेशेंट को हम इरेडिएट करते हैं, फिर इमेजिंग करते हैं। एक बार पेशेंट को सेटअप कर दिया, फिर इमेजिंग करके देखते हैं कि जो हमने प्लान किया है वही प्लान यहाँ एग्जीक्यूट हो रहा है कि नहीं हो रहा है, ठीक है। जरा भी मिलीमीटर्स में अगर शिफ्टिंग हो जाएगी तो वी विल मिस। सो दैट इज हाउ द ट्रीटमेंट इज डन, और उसके बाद पेशेंट का ट्रीटमेंट डिलीवरी होती है। सो दिस इज माय लास्ट स्लाइड, समथिंग अबाउट पैलिएटिव केयर। दिस इज वेरी वेरी इंपॉर्टेंट एस्पेक्ट ऑफ कैंसर केयर। हम सारे पेशेंट्स को तो क्योर नहीं कर पाते हैं, और स्पेशली अभी के सिनेरियो में पेशेंट्स बहुत लेट स्टेजेस में आते हैं, तो हमारा एम उस समय क्योर नहीं होता है। द एम इज टू palliate the patient, treat the symptoms, and would give a comfortable life to the patient as well as to the attendants also. क्योंकि इसमें कुछ पेशेंट्स बहुत टाइम तक लिंगर ऑन करते हैं उनकी डिजीज, उनके साथ साथ पेशेंट्स के अटेंडेंट्स को भी बहुत ज़्यादा सफ़र करना पड़ता है इसमें। So the entire aim of this palliative care is to treat the symptoms, give good quality of life, and at the doorstep. This is also very important. अब इसको देने के लिए हम पेशेंट को हॉस्पिटल बुला रहे हैं बार बार। सो अभी जितने भी एफर्ट्स हो रहे हैं कि उनके डोर स्टेप पे नियरेस्ट हॉस्पिटल में ये सिस्टम जो भी हम यहाँ पर करना चाहते हैं वो वहाँ पर अवेलेबल हो। प्लस इसमें साइकोलॉजिकल एश्योरेंस, कभी कभी पेशेंट्स को ये बताना कि अब पेशेंट में हम कुछ नहीं कर सकते, आप अब कोई और ट्रीटमेंट मत करिए इसमें, जस्ट लेट द पेशेंट पास ऑफ without any distress, ये बताने के लिए पेशेंट के अटेंडेंट भी डिसीजन नहीं ले पाते हैं कि हम ट्रीटमेंट नहीं कराएंगे। तो ये सारा एम है पैलिएटिव केयर का, which is very very important aspect of cancer care. So the key facts are that cancer can be cured if detected early. अभी तक जो कॉन्सेप्ट है कैंसर ठीक नहीं होता, ये सिर्फ इसलिए नहीं होता है क्योंकि हम अवेयर नहीं हैं, हम अर्ली डिटेक्ट नहीं करते। एंड हेल्दी लाइफस्टाइल कैन प्रिवेंट कैंसर डेवलपमेंट, दिस वी ऑल नो। अगर हेल्दी लाइफस्टाइल है तो डेवलप ही नहीं होगा। वैक्सीनेशन इज अवेलेबल बट नॉट फॉर ऑल। टाइमली ट्रीटमेंट शुड बी डन एट हाई वॉल्यूम सेंटर्स, ये भी बहुत इंपॉर्टेंट। अगर आपने अर्ली डिटेक्ट भी कर लिया तो टाइमली ट्रीटमेंट नहीं मिलता है, पेशेंट पहले कहीं और जाएगा, छोटे छोटे कई सेंटर्स के बाद फिर वो वहाँ पहुँचता है जहाँ उसका एक्चुअल ट्रीटमेंट होता है। एंड दैट ऑल टाइम वेस्ट होता है उसमें. Extent of spread to be assessed before treatment initiation. Single modality treatment in early stages, but multimodality is needed for advanced stages. Targeted therapy is the need of the hour, but at present is expensive. But later on, we expect that we have targeted therapy of most of the malignancies. Thank you very much.